Our last presentation in this section before we move into a panel discussion with some questions and answers is Dr. Karol Kaltenbach, who's the Director of Maternal Addiction Treatment, Education, and Research, a division of the Department of Pediatrics at Jefferson Medical College. Dr. Kaltenbach will be speaking on benzodiazepines and the pregnant patient special challenges.
Thank you. You've got the advance.
And then that's the red.
This is the advancer. Okay. All right. Thank you. I'm delighted to be here today. It's, I think, very exciting for Philadelphia to have a conference like this. What I'm going to talk about today, just to forewarn you, you're not going to hear anything different than from the previous speakers, especially the four speakers that focused on methadone maintenance, but this is just going to put it in the context of special population of pregnant women. So I'm going to divide this in terms of just a brief introduction in terms of how it relates to women and pregnant women, particularly talk about the special challenges related to pregnancy and some suggested strategies that we use at our clinic at Jefferson, specifically our outpatient clinic for pregnant and parenting women. So we've talked about the use of benzodiazepines. We haven't talked about it too much in terms of gender specifics. Benzodiazepines are one of the most widely prescribed medications to women. As we know, they're generally used to treat insomnia and anxiety. Women are much more likely than men to be prescribed benzodiazepines when they present to the physician for non-medical symptoms such as stress and life changes. And women are much more likely to be prescribed benzodiazepine for a longer period of time. So we do have some gender differences that we haven't spoke very much about yet today. In terms of opioid-dependent women, we know that they have very high rates of depression when they present for treatment. This one study, recent study, found almost 70% rates of depression, and I think anyone who treats women, opioid-dependent women, will concur with this. We don't have that wonderful concordance between Philadelphia and Pittsburgh, but I think if you look at the literature, you'll find that this is not an unusual finding, that this is typical. They have very high rates of anxiety, 78%. In terms of pregnant women, we don't have as much specific data, but in a recent study, I left the date off of this, I'm sorry, it's 2010, 37% of women in a treatment program had a primary mood disorder, and of those that were diagnosed with a primary mood disorder, 44% also had an anxiety disorder. The 36% who had a primary anxiety disorder diagnosis, of those 37% also had a mood disorder. So when you put those two together, you're coming up with the same rates of anxiety as the non-pregnant patients. So this is a very significant problem for people that treat women and people who treat pregnant women. If you do a literature search, you're not going to find much that any studies that provide data regarding the use of benzodiazepine by pregnant opioid-dependent women. Their data just aren't there. If you look at the National Survey on Drug Use and Health, which we heard about saw some of the data earlier this morning, it reports, for pregnant women, it reports on prescription misuse, but it does not provide data by drug category. It lumps them all into one category. So I just have to give you some local anecdotal data. We recently completed a clinical trial looking at the use of methadone and buprenorphine in pregnant women. It was a very rigorous clinical trial, and we had very rigorous criteria. And at our Jefferson site, we screened 199 women for this study, and 44% of the women at screening were ineligible for the study because they had a benzodiazepine substance use disorder, which was one of our exclusion criteria. So the women are coming into treatment having had a long history, if they are using benzodiazepines, they've had a long history of benzodiazepine use before they come into treatment. So this leads us to the special challenges. Obviously, this is a very high-risk population with very, very complex issues. What makes it special is that with the pregnant patient, we always have to consider both the outcome of the fetus in terms of what kind of interventions and what kind of strategies that we use. Whenever we're using medications during pregnancy, there's not very many medications that are really been well studied in pregnancy. So you always have to look at the balance the risk associated with untreated disease and relapse, especially when you're talking about opioid-dependent women, against the risk of using the medication. We also have to be very concerned about withdrawal. We all know that withdrawal from benzodiazepines is not pleasant and can be very dangerous in a non-pregnant patient, but we have to be very, very concerned that the pregnant patient doesn't exhibit any withdrawal because of the potential adverse effects on the fetus. Oops. So the other issue is that when you're talking about pregnancy, that all classes of benzodiazepine cross the placenta and are secreted in breast milk. So you don't want pregnant women breastfeeding who are using or abusing benzodiazepines. Most have a category D rating, which most physicians would not want to prescribe medications to a pregnant woman with a category D rating because that means that there is some evidence of human fetal risk, but potential benefits may warrant the use of the drug in the pregnant women. So the benefits may outweigh the risks. I just put this in here for your information because a lot of people aren't aware of it, that 4 benzodiazepines do have a category X rating. That means the risk involved in use during pregnancy clearly outweigh any potential benefits that there may be. In terms of what happens with these patients, what are we concerned about? Obviously, overdose is one of our first concerns, but again, how do we manage these patients so that we can not be so concerned about overdose, but also make sure that we're looking at the outcome of the fetus? Medical detoxification is often not available for pregnant patients, and if it is available, it may be too quick. Slow taper is recommended to avoid preterm labor or exacerbation of psychiatric symptoms. So we're talking about very slow tapers like Dr. McNicholas talked about earlier. Another confounding problem with this is that any pregnant woman who's maintained on methadone or who is maintained on buprenorphine, her infant has a very high probability of undergoing neonatal abstinence syndrome and will have to be treated for it. There's some confusion. All babies who are exposed to opioids in utero show signs of neonatal abstinence. The issue is whether the abstinence is severe enough to require treatment. And we know from many, many studies, including the mother study, that there's no difference between whether an infant has to be treated or not if the mother has been using methadone or buprenorphine. So if you hear people saying to women, pregnant women, you should be maintained on buprenorphine because your baby won't have to be treated for neonatal abstinence, please correct that. That is not true. There's no difference in terms of the probability of whether a baby will have to be treated. What is difference is the length of the treatment and the severity of the abstinence that has to be treated. Confounding that is if the mother uses benzodiazepines, whether it's an appropriate use or whether it's a misuse, the benzodiazepines exacerbates the NAS syndrome that has to be treated. It makes treatment much more difficult to manage and prolongs treatment. So now we come to the issue that has been talked about somewhat. Not all use or abuse is the same. Whether you have a legitimate prescription, management strategies may be that are required may be different. We know from the previous discussions that benzodiazepine use may be prescribed and the medication may be used appropriately. It can also be prescribed and be misused and not used appropriately. Or, as in many cases, the patient does not have a prescription but is dependent on illicit benzodiazepines, getting them off the street. Making it more of a challenge, these 3 categories are not always mutually exclusive. There's a lot of travel sometimes between the three different categories. So when we're talking about strategies as to how to address this, we have to know that even though we develop strategies for the best possible scenario and the worst possible scenario, that they're not etched in stone, that you do have to be flexible and you have to, again, look at what's going on with the particular patient. So these are strategies that we've developed over the years. I think they first started when Dr. DiMaria was medical director at Family Center, and they certainly have continued, and we've learned from it. And Dr. Ron Sirota is currently our medical director, and so these are strategies that have been developed as a treatment team approach, not just strategies that have been developed by the psychiatrist. So if the patient comes with a prescription for benzodiazepine, they must sign a consent allowing the physician and family center medical director to communicate. You've heard that repeatedly, how important it is to communicate with the prescribing physician. We also monitor biweekly GCMS. We do very, very close UDS monitoring. We may initiate a taper to reduce use. This does not, it's not the classical definition of a taper, it's more what we were talking about, what Dr. DiMaria was talking about. We're trying to taper if the woman is using an excessive amount, but try to start tapering her down to a more therapeutic range. Medical assessment is always done to determine whether appropriate medication is being used, whether she should be transferred to Klonopin, whether initially or later SSRI may be introduced to provide treatment for her anxiety rather than a benzodiazepine, and also look at non-medication options. Safety is always our primary concern when we're talking about the pregnant woman. So and we always put that in the context for the patient. We never present this to the woman that, you know, gee, you're doing this is wrong, and so we're going to put these measures in place. We always have a dialogue with her about how her safety and the safety of her baby is our primary concern, and that any kind of measures that we have to take are strictly to protect her and are to ensure her safety. So if she chooses not to give us a consent where we can talk to her primary prescriber, then she goes under the strategies that she'll be managed as if the benzodiazepine is not prescribed. So when we have women who are abusing non-prescribed benzodiazepines, again, we have to be very cautious about the interaction between the benzodiazepine, if they're using a lot, and their dose of methadone. Until we're sure about what's going on and we can see how the patient is responding, we limit the methadone dose increase from the initial stabilization. All of our women are stabilized in the hospital. So then when they're discharged, they're on a very stable dose. And so we make sure that we don't give rapid increases or increase their dose until we've got a good understanding of what's going on with their benzodiazepine use. We initiate a slow taper. We also assign a medicating time so that we can make sure that they're carefully observed each time they come in to be medicated. We utilize the 7-day medicating schedule. We allow for no take-home doses as long as we feel that they are using non-prescribed benzodiazepines. Again, we continue to conduct weekly GCMS urine drug screens, and then we make modifications to this strategy in accordance with how we see changes in their urine drug screens and clinical observations. So it's not that you get put into this track and then that's where you stay. It's that this is the initial strategy, and then based on how the woman is able to respond, then we can continually make modifications to that. We also look at additional non-medication clinical interventions so that the primary counselor, who in our situation, they're all master's level therapists, they discuss the safety issues with the patient continually. They have the weekly monitoring of the benzodiazepine levels. They talk about barriers to engagement or re-engagement in recovery. They talk about if we have to initiate any kind of behavioral contracts, they go into detail with that, again explaining that this is for the purpose of ensuring their safety and including time frames for change so that they know what has to be done in order for this strategy to change. Importantly, we also have multidisciplinary staff meetings, which include the psychiatrists, includes all the therapists, includes the ancillary support team, the nurses who do the medication, to discuss what's going on with the patient, what the UDS results are, so everybody is aware of what's happening with the patient, and if any dose change requests have been made. We also provide additional information through our prenatal classes. The women attend prenatal class every week that's conducted by our nurse coordinator. And again, the whole issue of how she's putting herself at risk by misusing benzodiazepines, what this is doing to her and possibly to her baby, and what kinds of supports may be helpful to her that we can put in place to help her move forward. And then it's also coordinated with the obstetricians. We provide obstetrical care for all of our women so that we can provide the UDS results to the obstetrician, so when she goes into prenatal care, she's also hearing it from her obstetrician as opposed to just from the psychiatrist and from the counselors. Then additionally, we have the therapist that's going to address her concomitant anxiety in individual sessions, for example, using a cognitive behavioral therapy approach. We also have a behavioral health peer specialist who provides outreach and support to the individual person to promote engagement in recovery, to give her the individual attention and support she needs to make the changes that are necessary. And then we've recently implemented mindfulness-based stress reduction intervention. We have a group once a week that focuses on how you can reduce stress, and we're hoping that we can make this into sort of a meaningful intervention for our women who need treatment for anxiety. We don't have the data yet, but we can say that the women certainly embrace it. They're really liking this approach and this technique. So in summary, even though we're treating the same patients and we're not treating them any differently than what you've heard earlier from the other speakers, pregnancy does present a special challenge, that strategies must be focused on the safety of both the mother and the fetus, that multiple types of clinical interventions are necessary. There's not one approach, and there's not one approach that fits all, that whatever kind of approaches you design, some of them are going to be more effective for one person as to the other, and you've got to have many, many approaches in your basket. But for us, the guiding principle is a combination of safe prescribing and effective treatment interventions. So thank you very much.